Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati on behalf of the International Cardio-Oncology Society, presenting highlights from a recent webinar that discussed biomarker use in prostate cancer. The highlight is presented by Dr. Darryl Leong of McMaster University. Dr. Leong is the Director of Cardio-Oncology, and during this highlight he discusses the issues of increased cardiac and vascular death in prostate cancer patients, general poor risk factor control amongst these patients, biomarkers as they are used for both cardiac and oncologic purposes, and he also takes a look ahead at future directions in the field. It's an excellent presentation and I hope you'll enjoy it. Also, don't forget to check out the ICOS website for other educational opportunities, and without further delay, here is Dr. Leong.
So what we'll do over the next half an hour or so is discuss the rationale for specifically cardiovascular biomarkers in prostate cancer, review the current evidence that exists, and talk a little bit about the future directions and where we think this could and need to go to make biomarkers part of mainstream clinical practice. So firstly, why are cardiovascular biomarkers potentially important in patients with prostate cancer? Here are data from the United States of over 700,000 men with localized prostate cancer in the SEER registry. You can see the causes of death there, and the cardiac causes of death are indicated by the maroon-colored columns, prostate cancer death by the blue columns, and what you can appreciate is that overall, and at various time points after a diagnosis of prostate cancer, a localized prostate cancer, cardiac death is a more common cause of death than the cancer itself. And when I tell my patients this, they're struck by it because all of the emphasis and focus is really on their prostate cancer treatment, whereas they are probably more likely to die of cardiovascular disease. Even in men with metastatic prostate cancer, where the prostate cancer is the predominant cause of death, the standardized mortality ratio, meaning the likelihood of dying of cardiovascular disease, is still 48% higher than similar men in the population who did not have prostate cancer. So clearly, cardiovascular outcomes are important to men with prostate cancer. So why is this? Part of it is the fact that men with prostate cancer, by virtue of their demography, perhaps other reasons, seem to have a high burden of cardiovascular risk. Here are some data that we've collected on nearly 2,500 Canadians with prostate cancer, looking at their cardiovascular risk factor profiles. You'll see that about a third have a Framingham cardiovascular risk score more than 17, which is associated with a 30% 10-year cardiovascular risk, so very high risk group. And in fact, 2/3 have a Framingham risk score more than 15, which is linked with a 20% 10-year incidence of cardiovascular adverse outcomes. So the burden of cardiovascular risk factors is high in this population. But it's not just that they have cardiovascular risk factors in abundance. The question is, how well are these controlled? Because we know that with evidence-based, guideline-directed medical therapy, controlling cardiovascular risk factors can reduce the incidence of cardiovascular outcomes. Here are some recent data from the Radical PC study, which we've now extended to several countries, looking at how well various cardiovascular risk factors are controlled relative to what guidelines say they should be, depending on the patient's cardiovascular risk profile, i.e., whether they've got a past history of cardiovascular disease, etc. So you can see that in general, risk factors are poorly controlled. And in fact, over half of individuals have inadequate control of their risk factors according to the guidelines across the board. And when you look at specific risk factors, we can draw your attention to the really common ones, poorly controlled ones. Central adiposity with a high waist to hip ratio is almost ubiquitous in men with prostate cancer. But blood pressure control, where we advocate for more aggressive targets in folks with higher cardiovascular risk, that was not at target in about 3/4 of this cohort. LDL levels, which again, the target varies a little depending on one's baseline cardiovascular risk and past history, but about half of individuals did not have an LDL cholesterol level at target. 1 in 5 were physically inactive, and 10% were still current smokers despite a diagnosis of a cancer within the past 12 months. So cardiovascular risk factors, one might argue, are inadequately controlled. But what I really want to make the point is that these risk factors are inadequately controlled in a population of patients that are seeing generally two physicians. They're seeing their primary care physician and their uro-oncologist. So we think that there is clearly a treatment gap here where, despite the fact that these patients are, well entrenched in the healthcare system, there is insufficient attention being shown on cardiovascular risk factors and diseases which may be more likely to kill them than the cancer itself. Hence, I think the rationale in my mind for why biomarkers might be really useful in prostate cancer. If we accept that the risk of cardiovascular disease and death is high in this population, but their cardiovascular risk is inadequately addressed, perhaps because it's out of scope for many oncologists, perhaps because of competing interests and competing challenges in primary care physicians, perhaps because of unfamiliarity with some of the guideline-based targets, could we find a strategy which can enable healthcare providers to easily identify patients who may benefit from more intensive attention to their cardiovascular risk factors? And it may be too much to ask the oncologist to check the patient's blood pressure, check their cholesterol, their HbA1c, and act on this. This is out of scope for them. But if we had a simple biomarker that could be applied when doing routine blood work, which gets frequently done in this patient population, to flag the individual who could benefit from a referral to a cardio-oncology service, then perhaps we've identified something of clinical use. And I again argue that the diagnosis of prostate cancer really may be an actionable moment. And perhaps people, when they get told they have a cancer, may be open to undertaking certain changes in their lifestyle and their treatments that improve their overall health holistically, as well as obviously wanting to treat and address their cancers appropriately. So what is the existing evidence that we have for cardiac biomarker use in folks with prostate cancer? As Dr. Lopez intimated, the evidence is limited in prostate cancer specifically. Here is one of the early biomarker studies. This was, as you can see, conducted in 17 patients with metastatic castrate-resistant prostate cancer or being treated with abiraterone. You can see that in terms of outcomes over 6 months, 5 individuals developed an adverse cardiovascular event. In fact, these was such a small study, they had to pool these 5 somewhat disparate and not necessarily congruent cardiovascular outcomes. You can see, though, that they measured NT-proBNP and troponin serially during these 6 months and found that amongst those who developed the adverse cardiovascular events listed above, that there was a somewhat higher NT-proBNP level and troponin level. And I guess this is a little unsurprising. And in fact, it's difficult to tease out whether these elevation in biomarkers occurred after the cardiovascular event rather than beforehand or predicting the occurrence of the cardiovascular event. But still, this was one of the earliest pieces of work done in this area. More recently, this is work from David Margell, who is in Israel, a uro-oncologist in Israel, where he led a 2-center randomized trial comparing the GnRH antagonist Darryl with a GnRH agonist in men with prostate cancer and high cardiovascular risk. This trial had about 80 participants, and what we show here is, I guess, a post hoc analysis of the baseline biomarkers that were measured and their relationship with cardiovascular events. So you can see that in the top row, at baseline, there seems to be an association between a higher level of NT-proBNP and a higher troponin concentration and the occurrence of cardiovascular events during follow-up. And this was especially true in the GnRH agonist arm, although more cardiovascular events were noted in that arm, and there were relatively few cardiovascular events in the GnRH antagonist arm, so a little difficult to draw any conclusions there about their relationship with biomarkers. For what it's worth, CRP and D-dimer didn't demonstrate the same sorts of patterns, although again, even though this was a somewhat larger study, was designed a little more rigorously, one might argue, still the number of adverse events were small in absolute terms, and clearly some more research is needed to confirm or corroborate these findings. Not all biomarkers are blood tests. Echocardiography, other imaging modalities may be considered, I think, a biomarker as well. This, to my knowledge, is one of the only studies looking at echo findings in patients before and after starting androgen deprivation therapy for prostate cancer. As you can see, there was a slight increase in troponin, but no change in BNP within this 6-month period. Neither was there any change in LV ejection fraction, but in this, unblinded study, if you like, there was some signal to an impairment of global longitudinal strain after the initiation of androgen deprivation therapy. So early data, lack of controlled data, and lack of blinded ascertainment of strain, but again, potentially suggestive that echo findings, markers of cardiac function and contractility may be affected by hormonal therapy. This was a paper that came out of Sebastian Smith's group in Poland very recently, looking at 49 patients with metastatic castrate-resistant prostate cancer treated with abiraterone. What was really interesting is when this group measured D-dimer, troponin, and NT-proBNP, you can firstly note that levels of these biomarkers were fairly frequently elevated in almost half of individuals. But what was, I think, really interesting is that elevation in these various biomarkers seemed to be associated, actually, rather than with cardiovascular outcomes, with death and treatment failure, so potentially more prostate cancer outcomes. And, there's been some thought for a while that some of these so-called cardiac biomarkers are actually quite pleiotropic and maybe markers of more generalized derangements in physiology. And I think it remains to be again corroborated whether these so-called cardiac biomarkers may actually have a role in identifying just poor outcomes in general or poor cancers-related outcomes, even in men with prostate cancer. So to spend a little bit more time on androgen deprivation therapy, because it is such an important part of the management of folks with prostate cancer. Up to 40 or even 50% of men with prostate cancer will at some point in their life be treated with hormonal therapy. And current indications include metastatic disease, as adjuvant therapy for many patients receiving radiotherapy as definitive treatment for prostate cancer, and for those who have biochemical relapse after definitive therapy. So very frequently used cardinal drug. Now, of course, most of you will know that 95% of androgen deprivation therapy is administered through GnRH agonists, where continuous stimulation of the anterior pituitary initially does lead to a surge in testosterone, follicle-stimulating hormone, and luteinizing hormone, which is somewhat undesirable. But this continuous stimulation of the pituitary then turns it off so that LH, FSH, and testosterone levels are suppressed, although there can be seen microsurges in LH and testosterone with repeat injections, and the FSH suppression is not what one would say is complete. The GnRH antagonists, initially with digarelix and now with relugolix, represent a relatively new way of administering androgen deprivation therapy. And by blocking the effects on the anterior pituitary of GnRH, they lead to immediate suppression of FSH, LH, and testosterone, and more prolonged and complete suppression of this hormonal axis. And so, what is the interest for cardiologists in this space? Actually, almost 10 years ago, this was some rodent work from Jonathan Pinthas's lab. Johnny is a close colleague of mine and a uro-oncologist. And they randomly gave these rodents either a sham procedure, orchiectomy, or hormonal therapy with GnRH agonist luprolide or digarelix. What they observed was that the digarelix-treated rodents had a lower burden of atherosclerotic plaque in their aortas and a lower burden of necrotic, so-called vulnerable plaque in their aortas as compared with the orchiectomy and luprolide-treated animals. And so this interesting animal data was really accompanied at the time with some post-hoc observations that perhaps the GnRH antagonists led to different cardiovascular event rates than the GnRH agonists. And in fact, recently, we summarized the randomized trials up to PRONOUNCE, which we'll talk about, comparing GnRH agonists and antagonists in humans this time. And we found that there was roughly a 50% reduction in the incidence of adverse cardiovascular outcomes reported in patients randomized to receive a GnRH antagonist as compared with an agonist. And so this, I guess, complements the data from Yoni Pinthas' animal work. Now, the PRONOUNCE trial, which was led by Dr. Lopez, was really a landmark study, I think, because it was the very first large prospectively done clinical trial with a pre-specified cardiovascular endpoint that was appropriately ascertained and verified. This trial was comparing the GnRH antagonist Darryl with GnRH agonist, and men were eligible for enrollment if they had ADT-naive prostate cancer and established cardiovascular disease, including coronary cerebrovascular and peripheral arterial disease. Before randomization, participants had their cardiovascular medications optimized by a cardiac physician, and then they were randomized in an open label manner to Darryl or leuprolide and followed for 12 months with a primary endpoint of mortality, MI, or stroke, and this was the study power there. Now, the trial, as many of you will know, was ended early by the sponsor when 545 of the planned 900 participants were recruited. And at this point, there were 26 outcome events and neutral finding for the comparison between Darryl and leuprolide. But this trial is important for a few reasons, one of which I alluded to earlier. But secondly, it really constitutes a large cohort of patients where cardiovascular outcomes are the focus. And we'll come back to that. But for this point in the presentation, the issue is that even though the findings from PRONOUNCE were neutral, I think there still remains some debate about whether or not GnRH antagonists offer superiority to agonists when it comes to cardiovascular endpoints. And if that is true, and there are ongoing pieces of research to try and show whether or not definitively antagonists offer some advantage, the question is, why might they be advantageous? Well, there is some interest in the potential difference in FSH and LH profiles between the antagonists and agonists as a potential reason for difference in cardiovascular endpoints. And Jonathan Pinthas has a grant from the Heart and Stroke Foundation of Canada to explore this in animal models further to see whether FSH could be a biomarker of adverse cardiovascular events in hormonal-treated animals. So I think this is an evolving field, and we'll see where this leads with interest. So to summarize what we know about cardiovascular biomarkers in prostate cancer, limited data, I think, would suggest that NT-proBNP or troponin may predict adverse cardiovascular outcomes in folks starting androgen deprivation. But I think before this becomes prime time, and as we'll get to on the next slides, we need more evidence in this space. There's also some very early evidence that global longitudinal strain may be impaired by hormonal therapy, again requiring corroboration, because these studies are small, the outcomes were not blinded, and really replication in larger numbers are needed. So how much larger should these trials be? What do we need to take biomarkers to the next level where we use them routinely and they become supported in guidelines? I'd like to actually change track to talk about a parallel field. There are a number of cardiovascular biomarkers we use every day. We use LV ejection fraction to determine who should get an implantable defibrillator or cardiac resynchronization therapy. We use troponin to identify folks at high risk of having atherosclerotic heart disease and ischemic heart disease. But another contemporary example is the use of troponin in the perioperative setting. And so this was really driven and endorsed by the guidelines owing to a study called VISION that was led by one of my mentors, PJ Devereaux. VISION was a prospective cohort study to evaluate the occurrence of vascular events after non-cardiac surgery in general surgical populations. And so PJ and colleagues recruited almost 22,000 individuals and measured troponin serially during hospitalization for up to 3 days. They followed these individuals for 30 days after their surgery, during which time 266 of them died. So just over 1% died. I want to draw your attention to 2 points in the table. Firstly, as maybe unsurprising now because it is an accepted part of care, but the higher the perioperative troponin level, the higher the risk of death. And so this is why troponin is used as a biomarker to predict the risk of future events and stratify individuals undergoing non-cardiac surgery. The other point, though, that I'd like to make is the very wide confidence intervals around the estimates of 30-day mortality and the hazard ratios, extremely wide confidence intervals. And this is in a study of 22,000 individuals. And the reason why the confidence intervals are wide are that, there were 266 deaths, but in each of the categories of troponin, the number of participants dying is in absolute terms fairly small. And so you can see that we need very large studies to get good precision in our estimates that will really guide our use of biomarkers. So with that kind of concept in mind, how does the field of prostate cardio-oncology fare? Well, I think one of the largest prospective studies to look at cardiovascular outcomes in a cohort manner is one we're undertaking in Radical PC. In 3,000 participants we've now followed for 3 years, you can see we've got 165 deaths, 112 cardiovascular events. And so we're just starting now to get to the sorts of numbers in this kind of research where we may be able to make some sort of inferences and derive some sort of models on cardiovascular biomarkers. And also pronounce, again, I mentioned it before because it is one of the largest prospective studies done with a predefined cardiac endpoint. Again, you see that there's about that 4 to 5% incidence of major adverse cardiovascular events. This was a higher risk group pre-specified in the protocol, but 26 events there. And so there really is a need for ongoing efforts to expand these sort of prospective studies that are well planned in advance. In addition to needing bigger sample sizes, we need bigger approaches to our biomarkers. The days when I think we used to take one candidate biomarker and test it in a cohort to see if it predicted outcomes, I think that's gone. And the reason is that single exposure biomarker analyses are costly in terms of time and effort. They're inefficient because you freeze and thaw the biospecimen and you end up wasting a lot of specimen. And nowadays with multiplex proteomics and even genomics platforms, you can measure hundreds or thousands of biomarkers on microliters of specimen. And this is a much more efficient way of screening for potentially useful biomarkers. So you can see in this simple figure here, this illustrative figure, that the more samples we can test simultaneously, the greater our statistical power and the greater our ability to detect biomarkers with fairly small effect size and to tease out some interesting signals in the data. And so I think that we need to apply both of these approaches moving forward in cardio-oncology and prostate cardio-oncology. So just to conclude, I think that cardiovascular disease is clearly an important outcome for men with prostate cancer. With the current evidence, cardiovascular biomarkers are not really ready for routine clinical use in this population, but because their clinical outcomes are improving, both especially in terms of their prostate cancer and its treatment, we need larger and more efficient research so that we can achieve further health gains, and hopefully cardiac biomarkers can form a part of that.
What an excellent presentation that was originally sponsored by Abbott, and we thank them for their support. Don't forget to check out the ICOS website and sign up if you're not already a member. This is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio. Treat cancer, protect hearts.